Thank you so much to the organizers for allowing me to speak today. I'm very aware that I'm the junior speaker today, so it's a real privilege to be here. So today I'll actually be speaking on behalf of myself and Tim, with whom I collaborate, but actually we'll be representing a very large collaboration of partners, not just here in the UK, but also Malawi and Tanzania, which comprises health economists, epidemiologists, software engineers, policy advisors, and many others. I'll be showcasing in particular the work of our Imperial sub-team, and luckily many of the members are here today, so they'll be signposted throughout the presentation, so you can go speak to them during coffee break. So today I'll be talking about the Thanzi La Onse model, so let me start by telling you a bit of what that is. So the ambition of the Thanzi La Onse project from the beginning was to work closely with ministries of health in partner countries, starting from Malawi as a test case, and to carefully listen to what their concerns are in order to comprehensively translate them into a single analytical tool that would represent them all at once. So what are these constraints? So they include, of course, the specific challenges that policymakers face. So this involves having to face a wide range of diseases and medical conditions in the population simultaneously. It involves tackling the provision of services for a population that is fast growing and also undergoing significant social and economic changes. And it also involves, as we just heard, having to deal with a wide range of behavioral and environmental factors, risk factors in that same population. It also involves the specific objectives that policymakers are trying to achieve. So this, of course, involves achieving overall reduction in mortality and morbidity in the population, but also ensuring that specific health and eradication targets are met within set timelines, and also ensuring that these policies are working towards broader goals of poverty reduction and enhanced equity in the population. And finally, it involves the specific constraints that healthcare systems have to deal with. So broadly, these could be all described as financial, but actually each type of constraint comes with its own specific challenges. For example, in the case of inelastic constraints, such as human resources for health and infrastructure, the need for long-term planning and investment in order to bring about these resources and maintain them. So given that these are the overall concerns, how does the model capture them? So Thanzi La Onse is an individual-based model where individuals have a wide range of characteristics, which include age, sex, income, but also likelihood of certain behaviors such as alcohol consumption, BMI, and many others. And it simulates all at once a wide range of diseases and medical conditions. So it accounts for 81% of deaths recorded between 15 and 19. And based on their individual properties and risk factors in the populations, individuals may become affected by one of these diseases or medical conditions during their lifetime, eventually start to display symptoms, and depending on their individual characteristics, potentially seek medical care for their condition. Now, crucially, what the model captures is that whether individuals are actually successful in receiving that treatment or not very much depends on the constraints imposed by the healthcare system. And this will, of course, affect the individual outcome, and then in the case of infectious diseases, the overall prevalence of that condition moving forward. So I'll start by talking about one specific type of constraint that I've been working on mostly, which is competition for healthcare worker time. So in this graph, you see all the different treatments that are provided at a primary care level facility in the model. So you see they span a wide range of diseases, so malaria treatment, HIV, TB, but also include antenatal services and many others. And all of these treatments require a certain amount of time from these medical cadres, so pharmacy, clinical, and nursing officers. However, the total capabilities available at every facility may not be enough to meet the overall demand for treatment at that care. This means that not everyone who will be requesting treatment will be able to access them on that day, and we captured this at every type of facility level included in the model. So once we have this infrastructure in place, there's then a huge number of questions that we can start to ask with the model. starting from whether this competition for limited resources can actually be mediated. So ensuring that we can achieve better health outcomes without investing more in the healthcare system, but just ensuring that the competition for them is mediated successfully. And so what we did was come up with a number of different strategies for mediating this competition and test whether they were successful or not in reducing the health burden. So what you see here is the total DALI, so health burden incurred under all of these different policies, and you can see that some of them actually managed to achieve reduction in health burden without expanding resources. And interestingly, they may achieve this result using very different approaches. So two of the best performing ones, one based on a cost effectiveness analysis, which significantly reduced the number of services that are provided at healthcare facilities, so gatekeeping those resources for very high impact treatments. Whereas the purple policy, the one focusing on clinically vulnerable individuals, allows healthcare systems to dispense any type of treatment, however, ensuring that individuals identified as clinically vulnerable, for example, children under 5, have priority access to those resources. Thanks to the model, we can also then look into data as to why policies perform better or worse. Oops, stop working. So for example, we can look at the evolution of the health burden under these different policies over time. And we can see that actually this cost effectiveness analysis is very effective in the long term, but in the short term actually incurs an increase in the health burden incurred, whereas prioritizing clinically vulnerable individuals makes the health system a lot more resilient to shifts in epidemiology and is consistently performing better throughout the entire period. And we can also then break down these gains by areas of health. And this sometimes allows us to reveal counterintuitive results. So for example, the fact that policies that were prioritizing the health of children are actually not the best performing in areas such as lower respiratory infections, or not as effective as policies based on cost-effective analysis, because they're not as efficient at gatekeeping those resources for individuals who truly need them. Another important question that we can ask is, what are the impact that investing or not investing in the expansion of the resources available in the healthcare system will have on the health of the population? And in particular, what are the health losses that could be expected from a lack of investment in healthcare workers? So this is a particularly important question for Malawi, because it's a country that's heavily reliant on development assistance for health. And projections forecast that this contribution will actually be steadily declining, as shown here as a fraction of GDP. And the investment of the government at the same period of time will not be enough to compensate for this loss, leading to an overall decline of the ability of the healthcare system to invest in its workforce. So what we did was come up, sorry, this is stuck. So what we did was to come up with a number of investment scenarios and see how well they performed. So this is a bit of a busy plot. So what we did was to come up with 6 investment strategies. One of them, the status quo, is basically aligning the investment into healthcare workers with the GDP growth. So assuming that the fraction of healthcare investment as a fraction of GDP will remain constant. We then looked at scenarios that kind of realized this forecast by the IHME, which therefore considers an investment below GDP growth, and then one case where the workforce is not expanded at all, and then 2 cases of growth above GDP. And from this kind of analysis, we can see a number of interesting things. So first of all, we're able to quantify this. So for the first time, we can exactly understand what the health return over a period of time would be from different levels of investment in the healthcare workforce. We can quantify what this decline in development assistance for healthcare will be. So it's expected that the extra burden will be between 7 and 60%. But also we can capture the fact that at some point this investment will start to tail off in terms of return. So exposing other frailties in the healthcare system, for example, referral pathways, healthcare-seeking behavior, and the rise of non-communicable diseases on the impact of this return. And once again, we can break this down by areas of health and find a few interesting things. So here in these plots, I'm showing the baseline starting point in these horizontal lines, and then your crosses are what we find under different levels of investment. So the good news that we find is that the heavy investment into HIV and AIDS programs in the past have now made this disease more resilient to lack of investment into healthcare going into the future. So you can see here that the burden would always be below baseline level, regardless of the level of investment. In the case of maternal and neonatal child healthcare, this shows very clearly how a continuous investment at current or above level is really required to prevent a decline in health due to those causes in the population. And finally, maybe most interestingly, we see how in the case of non-communicable diseases, the burden is rising steadily, but also completely unaffected by the level of investment into healthcare workers. So this is really highlighting how the scope and reach of current programs is really not enough to curb this rise in the health burden due to non-communicable diseases moving forward. Now, because we capture in detail the need for different types of medical workers in the healthcare system, we actually then can look in detail as to how this expansion should be focused on different types of medical officers. So this is work that Bingling has done, and what the model reveals again and again is that the answer is never quite trivial. It's never a linear addition of expected outcomes, and really it requires a model that is able to navigate the different shifts in services provided as you increase or decrease different types of healthcare workers in order to find one that performs best. Another type of constraint that's imposed in the model, by the model, has to do with consumable availability. So it's not just limited to healthcare worker time, but involves the availability of medication as well. So what my colleague Sakshi Mohan at York University did was come up with a number of consumable availability scenarios at prime care level. So these are all reflecting very achievable targets that are already realized in the country. So one group, for example, considers a scenario where all healthcare facilities can match parallel supply chains in vertical programs such as HIV and EPI. There's also scenarios that match certain benchmark facilities. So for example, the 75th best performing in the country, the 90th best performing in the country, and the best facility in the whole country. And also includes factors associated, which have been found to be associated with a high consumable availability. So for example, the fact that a facility may be managed by a pharmacist rather than not at all. And what she found was actually that by making these very modest improvements so here you see the average level of consumable availability under each of these scenarios, starting from a baseline of 52%, now showing here the averted health burden. And so you can see actually for these very modest improvements in consumable availability bring a very tangible benefit to the population. Now, to kind of give us a sense of how important these health gains are, if you look at a scenario where we're just ensuring that a facility is managed, the stock of consumables in a facility is managed by a pharmacist, you avoid the entirety of the health burden due to malaria over that period. And in the case of the best performing facility, the entirety of the health burden incurred due to lower respiratory infections. So the combination of human resources for health and consumable availability really allows us to combine these two perspectives into really understanding what it is that health system requires in order to be strengthened. And therefore, of course, we can combine them. So we can combine whatever chosen plan for human resources for health expansion with any plan to strengthen consumable availability over the same timeline. And we can couple this with improved healthcare seeking as a result of this improved delivery by the healthcare system. And then what's really interesting is that then we can combine this healthcare strengthening interventions with the scale-up of vertical programs. So in countries like Malawi, effort traditionally is focused on a number of very high-profile diseases, such as HIV, malaria, and TB, and the focus has usually been to scale up some of these programs. So, for example, improving the probability of viral suppression, if on ART, improving coverage of insecticide-treated bed nets, and many others. So the question that this model allows now to answer is which one is more important. So here, the red bar is your health system strengthening package. And then on the right, it's showed in combination with the scale-up of these programs. So you can see the left bar in each group is the one that doesn't include the health strengthening intervention, and the one on the right is the one that does. And you can see the huge impact that combining the scale-up with a health strengthening package really has in reducing the healthcare burden. And it shows to what extent scale-up of vertical programs are frustrated by existing weaknesses in healthcare systems. And if I can anticipate some of the concerns, of course, all of these interventions don't cost the same amount of money. But thanks to Sakshi, who's done a Herculean effort of costing every single item in the model, we now know what these interventions cost. And we also know what the return on investment is from each of these scenarios. And what we see again and again is that healthcare system strengthening interventions are more expensive, but they're always a better return on investment than just focusing on the scale-up of vertical programs. So what I hope to have demonstrated today is that Thanzi La Onse is a unique tool to evaluate these health system strengthening interventions really from a holistic and comprehensive level. What we're really interested in tackling next is the inclusion of emergencies into the system. So we've seen how these affect the health system in the talks today, but you can see how nicely they align with the structure of the Thanzi La Onse model. For example, by impacting the prevalence and incidence of medical conditions through, for example, the outbreak of new diseases, such as cholera in the case of Hurricane Freddie last year, but also in the way that they impact health-seeking behavior and the constraints on the healthcare system as a result. So we've already done a bit of work in this context, thanks to Bingling, who's looked at the disruption of healthcare services in Malawi. And what she's found is just how severe the impact on other areas of health has been. So drop in inpatient care, immunization, malnutrition, HIV, and many other appointments, really highlighting how important a modeling perspective that really captures all of the different healthcare needs is. But also what we're focusing on at the moment, and what Rachel in particular has been working on, is understanding the impact of climate change and weather disruptions in the provision of healthcare services. So she's looked at historical data on antenatal care appointment delivery in the past between 2011 and 2024, and looked at it in combination with historical precipitation data, and weeding out a large number of other factors such as altitude, type of management of facility, and many others, has found a relation shown here on the right between the total amount of monthly precipitation and the total number of monthly appointments being delivered by healthcare facilities, and which means that she was then able to couple them with climate predictions for the next however many years, allowing us to really quantify, to link the disruption of services due to climate in the model. So just to summarize, Thanzi La Onse gives us a unique insight into what makes healthcare systems stronger And in the future, we're really hoping to incorporate all of this perspective of emergencies into its working. So thank you very much.